and deafness. And I think it is that which informed the technical team at Busoga Health Forum to ask me if I could be part of today's webinar, and I said fine. Now, the content that I'm going to share with you is largely from my own personal experience as an ENT specialist and somebody who is charged with the care of people's ears and hearing. But yes, my personal experiences are going to be peppered by some extracts from official documents from the Ministry of Health of Uganda. There is a Uganda policy on hearing impairment and deafness, which was launched in 2004. And then we also have the latest, which is the global report, World Hearing Report of 2022. And I feel confident to go ahead in doing what I'm doing because I know some of the people in this audience are leaders at various levels in the health sector, medical superintendents, directors of hospitals, and directors of health services in the district. And there is a directive from the Ministry of Health, which was sent out in 2018, directing all those institutions to start actively, to start strategies to improve the care of people with hearing impairment. We'll show you some of the extracts in there. For those of you who have not yet been acting, you know that you have a basis, you have a policy framework behind you, you have a directive behind you as a basis for you to take the necessary action so that we help our people in the community who are facing the challenge of hearing impairment. Now, of course, definitely there are words we are going to be using frequently in this talk, and we don't want to take it for granted. If some of you already know this, please don't feel insulted that we are reminding you, but there may be one or two people who are not familiar with them. Impairment, which is a word that we frequently use, according to Cambridge Advanced Learners Dictionary, is just reduced effectiveness. And when we apply it in the field of healthcare, we're normally talking about body function, body structures, whose effectiveness has been reduced in one way or another. And then disability is a word that will also come up. And following the concise medical dictionary, a disability is a limitation to one's capacity to perform a social or occupational task. And so when we add the two, hearing and the impairment, of course, hearing is our ability to perceive sound in the environment. So if a person is not able to hear sound, and for purposes of being precise, the cutoff level we use is if a person can't hear a sound tone of 20 decibels, then that person is said to have hearing impairment, according to WHO. Now we hear or we perceive sounds from the environment using two ears. And so if you have one ear not functioning, but the other one is, its effectiveness is not reduced, we may, and if it is able to perceive a sound tone or which is softer than 20 decibels, then you are not regarded as having disabling hearing impairment. Now, when we start talking of being disabled, it is when if both of your ears are affected, but your best ear or the better ear has a threshold of over 25 dB. The 20 dB is used mostly for screening and academic purposes. But when we are talking about the disadvantage, how a person comes to be disadvantaged in the community, then we push it to 25 dB or more. That is how WHO starts saying you are disabled. If we are just talking about the functioning of your ears as a whole, we use 20 dB to say for your hearing is normal. It may be abnormal, but we do not want to say that you are disabled. We only say you are disabled if it has dropped. You need a sound loudness of a sound which is 25 decibels or more. If it is below that, you will not hear. If it's below that, you will not hear it. If you only require it to be at that level, then you will hear it. If that is the situation, we say you're hearing impaired. Now, all of us will know that hearing loss is a spectrum. Not all people who have hearing loss or hearing impairment have the same magnitude of the challenge. There are people whose hearing has diminished to such an extent that when you talk to them in a whisper, they will not hear you. But if you raised your voice like I'm doing now, and they are within the same room with you, you are conversing, we normally take a distance of about 3 meters apart as conversational distance. If you can talk to somebody at a distance of 3 meters away from you, and you don't need to shout, sorry, and they can hear you whispering, then that person is not disadvantaged. But if a person who is 3 meters away from you in a quiet environment, if you whisper, they will not hear you, then that person has a disability, is disadvantaged. Meaning, if they are in a conversation or they are in a discussion and there are people who are speaking softly, their performance is not going to be as good as those of others whose hearing threshold are better than that. So we are saying it is a spectrum. You have people who can hear whisper. You have people who can't hear whisper, but when you talk to them loudly, they will hear you. We also have people who will not hear whisper. They also not hear you when you talk loudly, but when you shout, then they will hear you. That is also hearing impairment. Some don't hear whisper, loud speech, they will hear. Others don't hear loud speech. When you shout, they will hear. But there are even those who, even when you shout, they will not hear. So we continue grading the hearing impairment or hearing loss until we reach a level where somebody, even if said there was a gunshot, there are gunshots in the room where they are, they can't hear. And when somebody's hearing capacity has reached that level, it is as poor as that they will not hear bomb blast in the town where they are, in a few kilometers from where they are, then we say these people are deaf. I would like us to leave it at that level, not take it too technical. That we have hearing impairment ranging from mild, if you can't hear a whisper, to moderate, if you need people to shout at conversational distance before you hear you, to severe, or if it reaches a level where you can't pick any sound, however loud it is, we say you are deaf. So the term deaf, when it comes to ENT practice, deafness is a very technical word. It means the worst degree of hearing loss a person can ever suffer. So that is to try and bring all of us to the same level of understanding these terms. Now, why are we talking to you, ladies and gentlemen? Our main aim as ENT practitioners and people who are in the world of taking care of people with hearing impairment is to try and influence your attitudes. We will discuss what we think are some of the challenges with the attitudes we harbor towards people with hearing impairment. But the main goal here is to influence your attitude, and we'll give you details. But specifically, we know that in order for us to influence your attitudes, we need to give you facts and figures. So we'll share some of the latest facts on hearing impairment. We'll also share with you the current thoughts and global trends on this subject of hearing impairment. And we will use personal experience to share with you some of those perceptions that we have observed or that our clients come and share with us. that we should also share with you so that we can change them. And specifically, my brother Eddie Mokaya is here to help us with bullet number 5, that's number 5, to showcase some of the positive trends that we may have to emulate or that will inspire us, including some of these documents and global movements. There are technologies that are available for helping people with hearing impairment, and we'll hint on some of those. My colleagues, the co-presenters, will come in with other details. So what is the situation like on the ground? Hearing impairment is on the rise globally, and in 2008, the WHO declared hearing impairment as a new and emerging public health challenge, one of those. And the WHO went ahead in 2017 at their 70th World Health Assembly in Geneva in May, and they made a resolution. And the essence of this resolution was to call upon the member states to change their perceptions and attitudes and start regarding hearing care as a global priority. And part of the basis for this kind of call and the concerns that have arisen in the world over hearing impairment is that today, as we speak, we have over 460 million people in the world living with disabling hearing impairment. And we said disabling hearing impairment is where if you sit in a room with other people discussing or conversing at an ordinary voice volume, you will miss some of what they are saying. You already disadvantaged. You have a disability. So we have over 460 million. It is estimated that this figure is going to be close to 660 million by 2030, just 7 years from now. And in 30 years time, under 30 years time, that is by 2050, we will have a billion, close to a billion. The precise figure quoted is about 900 million, which is close to a billion people. Now the danger here, Uganda is regarded as a country of younger people. What the trends are showing, what analysis is showing, is that hearing impairment is now beginning to affect mostly young adults. People aged between 15 to about 32 years of age. They are the ones who are now feeling the brunt of hearing impairment. Now, coming close home in Uganda, there have been studies conducted around the year 2000. And Chris, who is in academia, might have to share with us the latest. I am basing on documents of around 2000. Dr. Turitwenka, a retired senior ENT surgeon, conducted some studies in Masindi. I think there were 2, which revealed that 5 to 10% of Ugandans have disabling hearing impairment. 5 to 10%. That's why we are getting this figure today. If the population of Uganda today is estimated at 42 million, it means we have about 2 million people amongst us with disabling hearing impairment. What is even more scary is that about 2%, 0.2% of Ugandans have the worst type of hearing impairment. Once your hearing impairment crosses the boundary from mild, moderate to severe, you are edging towards that bracket of people with hearing impairment where support is either unavailable or very, very costly. Technology is helping. About 15, 20 years ago, to say for you, yours is a gone case. There is nothing that can be done. But now technology is helping. Eddie Mukaya will help us with some details of some of the technological advances that are now bringing hope on the a smile on the faces of people with hearing impairment. The challenge is the cost. Now, the other thing that the situation analysis reveals is that the causes of hearing impairment are changing. Previously, especially here in the third world, the developing world, in the tropics, most of our problems centered around infections, ear infections, meningitis, other cerebral infections like measles, mumps, encephalitis. Now, things are changing. I think partly due to widespread immunization, but also there is widespread use of antibiotics. This has challenges. There are some antibiotics which are being widely or excessively used and they challenge. But overall, what they have done is to help to tilt the balance from hearing impairment in this part of the world being mostly due to infection. Now, the use of antibiotics coupled with technological advancement is tilting the balance. We are seeing now people with more hearing impairment caused by other things. And this is why the theme of World Hearing Day this year is not infection, it is not trauma, but it is noise-induced hearing loss. That's where the focus is shifting. Actually, in the Western world, I'm told the estimate is that there are over 40 million young adults aged between 15 and I think 32, over 40 million who have disabling hearing impairment, which is attributable to exposure to unsafe sound levels. Okay, this one we wanted to jump. Before we go too deep, we need to know, why should anybody be bothered about somebody not being able to hear well? There are consequences. There is an impact that people will suffer when they have hearing impairment. And here we are going to look at it stratified. Evidence shows that the consequences or the impact vary with age and the severity. We have already mentioned the severity. Age, we don't have to go too far. Now, what is the impact of hearing impairment, especially of the magnitude we are saying is scary, the severe form? It also, among children, it also varies, the impact is going to vary according to the precise age of the child. There are children we say are prelingual. Prelingual children are those who have not yet learned to speak, and this is 3 years and below. And among the consequences we are going to get, if you have your child who has not yet learned to talk or to speak, one, they are going to have they may never develop spoken language, by the way, they may never talk. If they do, they are going to be too slow. Two, generally learning is going to be a problem. You know, before the age of 3, there are so many things that a child has to learn. That's why they are very inquisitive. They're always asking questions. What is this? Who is that? What is the other? Now, that is all communication, and mostly verbal communication based on sound, environmental sounds. When a child doesn't hear the name of Bisso, no matter how much they know Bisso, don't expect them to pronounce the name of Bisso. If a child doesn't know the word computer, has never heard it, they will never pronounce the word computer, and that's how it goes. And those are the challenges when the children suffer hearing impairment before they have mastered spoken language. Of course, some of the prelingual children, people are now taking children to school even at the age of 2 or 2.5. They are going to be very poor school performance. They are going to have poor social integration. By the way, some of them just suffer isolation because all of us are attracted. Most of us are attracted to children who are exciting. You talk to them, they talk back. There is that fun you get from talking to a child who is active. They participate with you in whatever you are doing. But if they are the type who seem like they are withdrawn, they may be isolated and they can end up being victims of neglect. We've seen this in some villages where children are locked behind in a specific room in the house, especially those with some of the worst forms of hearing impairment. It is on record. Some families feel embarrassed. If the child had already learned to speak and then they lose their sense of hearing, still, much as they have learned already to talk, if some of you have met these children, you could find a person who had previously learned to pronounce the word Bisso or the name Bisso, beginning to pronounce it as before or before. Speech starts to deteriorate, even if they had already learned to speak. By the way, this happens even to adults. The social isolation we talked about earlier for those who are prelingual will happen even in postlingual children. Age 6, 7, 8, they have friends, they have playmates in school, and we have testimonies. We have testimonies of children who have felt isolated and have actually become depressed. Last year on World Hearing Day, I had a testimony of a child who had been doing very well in class from nursery up to when he was in P4, and then he suddenly developed a febrile illness and he was treated with drugs that damaged his hearing. He started repeating class in P4. And last year he was supposed to be in P7, but he was still, I think, in P5. And what made the mother bring him to me, she had just gone and opened his book and found he had inscribed somewhere in very big bold letters, "Life is difficult for me," in his school book. So the mother called him and asked, "What is this writing about?" And then the child opened up and said, "You know, at school, my former friends and playmates nowadays don't want to associate with me. Even my teachers, even when I raise my hand in class, teachers take long to see my hand. So I feel life has become very hard for me." This is a child of around 12, 13, 11, 12 years. And this is what can happen. Some of these also suffer wrongful victimization. I'll show you towards the end of this talk what I mean by wrongful victimization. We have accused them of becoming stubborn, becoming disobedient, because you will tell a child, "Go and bring your school homework and we look at it," but you are talking at a normal conversational voice and you are not aware that they have lost their sense of hearing and they will not respond. And you might think this child is becoming big-headed, they are becoming disobedient. In this case, they might suffer punishment. So that is children. Want to rush to adults? Yes, we also have adults who suffer hearing impairment, and it leaves them with their consequences. The greatest one, of course, opportunities generally reduced. If they are still in pursuing academics, they're going to have reduction, decline in their performance in school, in class, because some of the things taught by teachers who are just speaking will be missed. Similarly, adults who are searching for jobs will find it difficult to compete with us who are hearing able. And those who are already in employment, by the way, could easily lose their jobs. These days in countries like Uganda, leadership is a form of, especially political leadership, is a kind of occupation which brings rewards. it is going to be very difficult for somebody who is hearing impairment to hit the campaign trail and convince voters when he's struggling to hear them. Even in relationships, there have been marriages which have broken up because one of the partners suddenly became hearing impaired. So social isolation, gender discrimination, psychosocial effects, people get depressed, they lose confidence, and we have had people develop suicidal ideation because life has become hard. This is what I discussed with the mother of that young boy who wrote in his book, Life is Hard. I told her this guy could suffer a worse degree of depression, and some of these end up committing suicide, and we may never know why they have done this. Now, many of you could have heard a story when we talk about wrongful victimization. Even adults can suffer wrongful victimization. We mentioned it in relationship to children. But at the beginning of lockdown, I think in 2020, around May, April, May, June last year, you could have read a story or stories of a gentleman who was shot dead by security operatives on the streets of Lira. And his only problem was they were chasing people off the streets during the when they were enforcing lockdown, and this guy was deaf. He couldn't hear, and he was shot dead. That story, I'll look it up. It was in the press, probably written about, and it was also on TV. But many of you have heard that story. That is how a fight can go. If somebody has hearing impairment, they have those dangers. They're exposed to dangers. Some of us live in insecure areas. You want your ears to help you at night to hear who is moving around your house or what is going on. You need to know if in the neighborhood they are breaking the doors so that you lock yours even harder. If you are hearing impaired, you are at a disadvantage. People will break your doors, they will break the locks until they reach you when you have not heard that somebody is breaking into your house. So there are those opportunities, reduced opportunities, and there are those dangers that can cause bodily harm to a person with a bad degree of hearing impairment. Now, there are a few perceptions. We said we intend to influence perceptions, and these require correction. I decided to list these two. One among us health workers, one of them is we tend to quickly imagine that every ear that is feeling blocked should be shrinked, and ear shrinking has its own challenges. Or that any ear problem or all ear problems require ear drops. Yes, there are those which require ear drops, but there are even those where ear drops actually are a danger, depending on the precise problem in that ear and the ingredients in the ear drop that we are using. And so we think some of these need to be addressed. In the general public, here where I have been working in Mbale for the last 20 years, people tend to think that the white liquid which comes out of the ears, here in Mbale and in Bugisu region, they think it is milk, and they attribute it to the carelessness of the mother who left milk to drop into the ear. And unknown to them, that is pus, which is a sign that a rot is taking place. And so those of us who interact with members of the general public and they tell such stories, this talk is meant to empower you to be able to correct those wrong perceptions. There is this belief that if a child clocks 5, 6 years and they are not talking, the problem is that their tongue is tied down. Very wrong again. And some of these children have been mutilated repeatedly. And yet cutting the tongue frenulum is not going to change anything. Those children, like I illustrated earlier, if you have never had the what the French call a book, you never pronounce that word. I think they call it un journal. You will never, if you have never heard it. So we don't expect the people who have been hearing impaired at birth, severe degree, to be able to talk because they can't say what they have never heard. And then the perception that children with the worst degrees of hearing are a gone case. Nobody should even waste time taking them to school. It is a waste of money. Eddie Mukaya will share with us what he has seen in the community out there. Those are the fear I managed to come up with, but the people around here are all intellectuals. You can prolong this list. This is just to stimulate your thinking. There are also a few actions we engage in and as the health workers that we think we need to address because they pose a danger to ear health of the population that we have. One of them is these days things are changing. We are quite quick when we get patients. The old way of dealing with the patients where you take full history, you examine them, you review all the body systems is quickly gone. The moment somebody says, I have headache and fever, sometimes the quickest thing is go to the lab and they do malaria RBT, checking for malaria. Yet if you took a deeper and more detailed history, yes, this person who is having headache and fever may not necessarily be having malaria. They can give you details of how the ear has also pain, how the ear is feeling plugged, how they have recently had the flu. And then, you piece facts together and you have more differential diagnosis. The other is apparently innocent, but a dangerous act we see a lot. There are drugs that are known to be a danger to the ear, but we use them so liberally. One of them is gentamicin. And these days, it is becoming a drug that people so easily prescribe, and streptomycin. Streptomycin years ago used to come out only for TB, but these days in some of the places where we are, like here in Imbali, there's so much diagnosis of so-called brucellosis. And then we quickly go for gentamicin, we go for streptomycin. We feel these are some of those issues that we as health workers, we need to check ourselves. We've earlier on mentioned excessive or injudicious use of eardrops. I think we have a lot of faith. But the other thing that we need to work on as the members of the medical fraternity is we should not delay to refer patients. If somebody is complaining of fever and earache and I don't have an otoscope to look in that ear to see if the infection, the site of infection causing a fever is not the ear, I should ask a colleague who has an otoscope or the skills to assess ear health to look at them before I continue treating. Improvement, what can we do? I've already mentioned most of these things, but some of the things I want to rush to. I said, okay, getting the diagnosis right is okay. Now, when it comes to people with hearing impairment, if you are not very patient, bullet number 5, if you are not very patient, you can give up when you are taking history from a person with hearing impairment. You need to shout, and for some of us with long patient queues, if you have 60 patients and one person requires you to shout, and it is past lunch time, you have not eaten, if you are not very patient, to get history from them can be a nightmare and you could give up. But they need us to we need to understand them. We need to show compassion and we need to win their trust. Even if you can't, if the queue is so long that you cannot have the time to patiently listen to their history, which you extract with difficulty. Once you have established good rapport with them early, it is always possible to schedule a meeting with them to a time when you are not too busy. Now, the other is one of the things where we can get challenges and people with hearing impairment fear to come to us or they lose confidence in us is if we breach confidentiality. And this is very easy. I sometimes find myself shouting to get the details of what has happened to this person. And yet the other patients are close nearby. And there is that danger that there may be information they want to share with you, but because the environment requires shouting and other patients are close by, that can strain the interaction between you and them. Some of the things that are taking place now, which give us hope, these are we have called positive trends in the care of people with hearing impairment. We have these declarations, which we are basing on to say, okay, so the world has woken up and it's on the same page with us. We have the World Health Resolution of 2017, which called on member states to make hearing care a priority. And then we have the World Hearing Report of last year, which gives us a lot of details about the causes of hearing impairment and what we can do to reduce the risk, the risk to people's hearing. Ministry of Health has this policy document which we can rely on. And we have this annual commemoration of World Hearing Day every 3rd March. Now in Uganda, you will not believe this, but Ministry of Health has donated the equipment. So the Ministry of Education has donated equipment for screening of hearing impairment in newborns. A child, a newborn as young as 3 days, we can screen and be able to tell that their hearing infrastructure is okay. But this equipment was donated to us in 2019 by the Ministry of Health. Unfortunately, it might be lying idle at some of our regional referral hospitals because there are no ENT practitioners. One of those is the Kabale, if I'm not mistaken, Moroto, Arua. They have this equipment, and yet they do not have ENT practitioners there. In the Ministry of Health policy on hearing impairment and deafness is where we have got this situation analysis. And they have a very good policy goal, which unfortunately is not being implemented. They have recognized the inadequacy of services in the country with only a few fully equipped ENT centers. And the policy goal, as stated as far as early as 2004, is to have all these regional referral hospitals equipped with people who have skills in ENT care, but that is still a pipe dream. There is a very good framework how the policy should be implemented, including economic assessment of the gains that we can get if we have people with skills in treating people with hearing impairment or preventing hearing impairment deployed. There is an economic assessment, but seems like it has not been given enough attention. World Hearing Report, the key messages there are that we are threatening the 1 billion mark of people with disabling hearing impairment under 30 years from now. And it calls upon us to pay attention to the multiple and diverse causes. And it also highlights the challenge of technology, which is becoming a danger to hearing impairment. But the good news, they remind us that 70% of our hearing problems are caused by factors that are preventable. Now, World Hearing Day 2022, the emphasis, that is the theme, to hear for life, listen with care. And the essence is that we should protect our ears against loud sounds or noise, jealously. And one of the key messages is that the world is getting concerned because exposure to loud sounds is on the increase, and many of the settings where we get exposed to these loud sounds are actually recreational areas, nightclubs, discotheques, even fitness classes. We know that we need to go for fitness classes because we have to exercise to be healthy. But when you go to some of these places where fitness classes are held, the volume of music being played there is unsafe. And then we have smartphones with apps for playing music, which is easily downloaded. And some of our children and youth are playing this music at loud levels. And the more regularly people get engaged in these activities which expose them to high volumes of sound, the greater the risk that they will develop hearing impairment. I want to pause there for now and acknowledge those agencies listed up there. But most importantly, I want to acknowledge or to pay tribute to a certain senior consultant physician in Mulago. In 2001, when I was struggling to find an appropriate topic for my dissertation for my M.Med as a requirement for my M.Med, he walked to me in the ward with his 4-year-old niece, and he requested me to look at her ears. Reason, a week earlier than that, he nearly caned that young girl. She had been a very humble girl, always obedient. But then in the previous few weeks, he would tell her, go and do this, and she would just stare at him. Don't do that, and she would just go ahead with whatever she was doing. So in his mind, was this girl is becoming stupid, big-headed, he wanted to beat her. Then one evening he was returning from work. The girl was in the sitting room and they were playing with other playmates. As he passed by, he heard her telling the other, please speak louder, I am not hearing. That made him rethink the perception he had got about this girl. So he brought her to me to look at the ears. I was very ignorant at that time. It was, I think, my first month in the ward. So I sent this child for a hearing test straight away. When she went for a hearing test, she met one of my seniors who examined the ears and identified that this girl had accumulated the fluid in the middle ear. We call that otitis media with effusion. So she put her on treatment and then gave her an appointment to be brought specifically to me to review. And when she came and I reviewed, I saw what the senior had identified. That made me develop instant interest in researching this ear problem called otitis media with effusion, which can earn children beatings, which can make children have slow progress in school, which can make children to be isolated and falsely victimized. I owe those to my M.Med dissertation, which you can see on the right on your screen. Thank you so much.
Okay. Thank you, Dr. Fred Bisso, for that very elaborate presentation. And you've taken us through almost everything on the ground and globally. Just to add on to that, the policy of Ministry of Health is to test all children 0 to 5 years before they are born. And like you said, many of them are not actually being, the policy is there, but the work is not yet on the ground. So since last World Hearing Day, we had made it a point to test this policy. And we chose, as Makerere, we chose 3 hospitals, which included Mbale, Gulu, and Imbarara. And the reason for the choice was these hospitals have fully functional ENT units. So we tried to find hearing impairment in the postnatal and immunization clinics. So all children that were during the time of study that were coming for immunization or in the postnatal ward were tested using the equipment that Ministry of Education donated to Ministry of Health. The preliminary results, the paper is soon coming out, and we found that 3% of those children who are going through those clinics were found to have some degrees of impairment. So the problem is there, but we need, and most importantly, that it is possible for us to run screening of hearing in all the hospitals, because these tests are not hard to do, and the nurses running those units can easily perform them. So we find that we could be on the same level with all other nations that are implementing this policy of screening. I know it's difficult, but we are not far behind from our other regions like North Africa or South Africa that are implementing these policies. That's just to beef up on the presentation Dr. Bisso has said. Now, we would like to invite Mr. Eddie. Eddie has got first-hand experiences with a child who developed hearing impairment, and actually born deaf, and currently this child is able to hear and perform normally like a normal child. We would want to hear that, and how he deals with these children who are being rehabilitated at this center, and what perceptions parents have when they have kids that have hearing impairment. What do other parents do when they get that hearing impairment? What small stories really happen as along the hearing impaired child? Mr. Eddie?
Instead of us looking at how do we minimize the impact of hearing loss on this individual, we begin to now think inside, and many families break, like Dr. Bisso has ably said. Children lose, they are sent out of school for lack of proper diagnosis. Siblings begin playing tricks on her or him. The whole thing becomes a mess. Now, I want to talk about what is rehabilitation, because that is very critical in such a situation.
Eddie, can you kindly share your screen?
I am actually sharing my screen. Let me
Really?
see. Okay, let me do that again. Let me do that again. Share my screen. Okay, Dr. Bisso, can you take off your screen? Okay.
I have stopped.
Okay.
Yeah.
Share my
Come
screen.
on.
Okay, thank you. That's my screen. Are you able to see it now?
Yes.
Okay, so I'm looking at rehabilitation, and I hope it can. Yes. So there are stages for those who have lost hearing loss, who have lost hearing at an advanced stage, when they have been able to learn language, they have been immersed in the mainstream community, and they're able to go about with their life easily. Now, to those, it is much easier. It's what is being referred to as the rehabilitation. And Dr. Bisso talks about the postlingual hearing loss. Now, for prelinguals, it becomes completely different. The game changes, because it is about now how early you have intervened in the hearing loss, how early you have fitted whichever technology or appropriate hearing aid you have, because the later you do it, the less results you will be able to get. So you begin to work with this child, even if he's 4 years and you have given a hearing aid at 4 years, his hearing age will be 1 year or 0. So that is the perception. When somebody is fitted with a hearing aid and is 6 or so years, people will begin to say, oh, this guy is 6 years, but he's behaving like a 1-year-old. Yes, you need to understand that he's only 1 year of hearing. And you cannot, the brain is wired that what you give it is what it will give you back. Doctors will tell you that hearing actually starts when the cochlea has developed. And the cochlea develops when the child is still in her mother's womb. We are told that between 24 to 26 weeks, the cochlea is fully developed. And by then, the child will start hearing the voices of the father, the community around. When the mother is cooking in the kitchen, the child is hearing the sound of the cutlery. Now, for a child who has not had hearing up to 8 years, it will be very difficult to do that. So how do we do that? Habilitation comes in. Now, we just now need to begin to deal with this person. So, in making sure that we get the most out of re-stroke habilitation, parents need to be informed. You realize that everything about what we've talked about, like Professor Peter Weiser has asked the question, without the early screening protocol that Dr. Chris and Dr. Bisso are working so hard that this country will embrace, diagnosis happens at home. The father and the mother, the siblings, are the first people to recognize that this person doesn't hear. So you begin making decisions of now, which mode of communication am I going to use? Which type of intervention am I going to go with? Which schools am I going to take my child? Because schools, even when they are fitted with hearing, some kids are fitted with hearing loss, some schools will deny you entrance because of a hearing loss or because of the technology you have. The other thing about technology is about the perception that once I have a hearing aid, thank God, my hearing has been corrected. No, it's not like I have my glasses, I'll come out of the optician's office and my sight will be corrected. Hearing loss is different. So Dr. Bisso talked about being patient. You have to be patient to close the gap between the hearing gap and the chronological age. Now, that is critical. It's critical, and that's again the role of re-stroke habilitation for those who are postlingual and for those who are prelingual. So at all this, we need a team, a concerted effort from the team to set specific goals which are going to help this child, this person at every stage. Because today we might be dealing with the siblings, tomorrow we'll be dealing with preschool, the other day we'll be dealing with teenage life, the other day we will be dealing with employment. And all these, we need to work together as a team. I'm going to end here. This is actually my last sharing, to focus majorly on how do we empower families, because for those who have children who are normal, you don't employ anybody to teach your children how to talk or how to converse. Language happens at home. So we need to empower families. We have a strategy we call auditory verbal therapy, where we make sure that the families are at the center of habilitating their child. So empowering families, providing knowledge and confidence to the family so that they can raise up beyond the notion of stigma that society has brought about, so that parents are able to focus or even on their extended family for their own social support, but again, using appropriate spoken language in all the routine of the day. I'm talking about this because this is what I actually did as an individual. And like Dr. Chris has said, I have now a 15-year-old. She talks, she uses her phone. She is at school. She's actually going to 9th grade right now. She's asking me questions. Daddy, what do I want to do? Do I want to study audiology? Do I want to do biomedical engineering? And you know, now you wonder how a child who if she wasn't talking, how this all could be. Because there are different ways of communications. But a child needs to be able to communicate with you. So we look at ongoing diagnostic and assessment interventions that we need to go with. And as we do this, we learn about different states of normal development. My child is now at this is what I expect. And that comes also with intervention. Now, talking about the different stages of normal development, Dr. Bisso asked me to talk about a little bit about technology. And I'm talking a lot about hearing aids and cochlear implants. Now, for hearing aids, they will be able to aid your hearing, depending if you have mild to moderate, then that can be helped. And again, you are able to go back to about 20 decibels. But what hearing aids are doing, they are amplifying the sound and helping you using the same hearing pathway.
So the guy will say, this guy got mad and never built the headset.
No. Okay, so using the same hearing pathway. Now, when you amplify everything, the high frequencies amplified will not aid in speech because you have what we call the speech banana, and this was about 25 decibels. And again, Dr. Bisso ably placed that. You are able to sustain a conversation at 25 decibels. Now, if you are beyond that, the hearing aid may not be able to help you. It will just amplify everything, but still work with your normal hearing pathway. Dr. Chris is one of the leading surgeons for cochlear implants in Uganda. And now we are able to see that you can bypass all these other parts which are not working well, including the middle ear, and completely communicate with the inner ear, which is the cochlea. But again, that hearing is different. The other was acoustic. Now, hearing with the cochlear implant is actually electronic. Last year, we implanted a 45-year-old man, and he was postlingual. He had taken about 3 years without hearing. So when we switched him on, whenever we're talking, was like, are you the one talking? I'm hearing as if it's metallic. I clapped my hands under the table. He asked me, are you the one clapping? It's as if they were hitting metals. Now, what am I talking about? There is again another way to work with the brain to be able to assimilate this new sound. So that will all work. So it's not that once you have the hearing, the cochlear implant put in, it's now electronic, no longer acoustic. These sounds are different, and we are stimulating at different levels for example, to be sure that you're hearing all the frequencies. What the cochlear implant does actually gives you better hearing in the high frequencies than the hearing aid. And you're able to understand speech if you have good rehabilitation or habilitation. So what are we doing? We want to make sure that we provide families with the best possible auditory language and learning environment, so that all this can happen when the parents are in the know. I will end because we're talking to Busoga Health Forum. I believe this is a place which can influence decisions. World Health Organization has, Dr. Bisso was talking about the World Report on Hearing. I just want to end with a summary. It's a very big document, but the biggest summary, there is a snapshot of that report. They summarized it into an acronym. What are the things that we should be doing at our personal level? And now, because we have professionals in this Forum, we can be able to see that hearing screening and interventions are part and parcel of what we are doing in our communities. But also, like Dr. Bisso said, making sure that we take care of the ear diseases in time to prevent and manage hearing loss. Also, we need to advocate for access to technology. I was away a few days ago, and in this particular country, when you have a hearing loss, Dr. Chris was talking about we are able to get hearing loss by three, on day 3. There is a strategy, they call it 3036. They detect your hearing at birth. By 3 months, you've gotten diagnosed and you can be intervened either with any form of rehabilitation or habilitation. By 6 months, if you qualify for a cochlear implant, they can put it in. Now, technology has revolutionized medicine. So has it revolutionized hearing loss. We need to embrace technology. Schools for the deaf in many countries have closed. In many countries, there are no rehabilitation centers for deaf people because children are getting this technology early and they are being mainstreamed early. And World Health Organization says that unaddressed hearing loss costs us about $16 billion. And now you're talking about if I intervene with technology in my child. Again, that was my story. I looked at my daughter, I'm like, she's a girl, she's deaf, and all these stigma around deafness, what am I going to do? I had to invest in her life so that she can be independent. When she's independent, she will be able to scale up to her potential, be productive in community. She's not only productive at home, she's productive in community. And at the end of the day, she will get a job and start paying taxes. And now this is how to understand taking care of somebody who has this disability. Dr. Bisso said, it is a silent disability. It is invisible. It's not like the other. And right now in Uganda, it is on the spectrum of disabilities. When we take people who are disabled, the lame who are talking, maybe the blind one eye who are talking, whenever there is a debate, they take the biggest share of the cake. So the deaf people are still left behind. And let me say, hearing impairment is still on the least step of the ladder of disability services in Uganda. Thank you so much, Dr. Chris.
Thank you, Eddie, for sharing with us and those insights. I would like to caution that hearing impairment is a disability that you can get at any age. It is not, you'll never know that one time you could be impaired, because those of the children who get it congenitally get it early. But even me, you, or anybody else, you can be impaired even tomorrow. You never know, presbycusis, head trauma, a funny injection that you got from a funny clinic, the drugs like TB drugs. So anybody at any age can actually develop this kind of disability. So as I'm saying this, that as Eddie has said that deafness and hearing impairment are not well lobbied for, and we would request all the leaders on this forum to always, when they hear something about impairment, hearing impairment, give it a hand, give it support. Let the screening begin. At least we have done a pilot that it could be possible, and it's possible to be done. We could do this, the 036 later as we go ahead, like Eda has said, but at least we are able to convince people that we can start screening at 0, and then we could review them at 3 months, and then make final diagnosis at 6 and take interventions by 6 months. So thank you, Eddie, for those insights. I will take these questions, a few questions that we have on the forum, and then I will ask some, I will take them, and others will be, I'll ask Dr. Bisso to answer them. There is a question about quinine injection. Dr. Bisso, are you still on?
I am
Hello?
here, please. I am
Yes.
available, please. Yes.
Yes, there's quinine injection and hearing loss. Kindly, shortly, with the short answers, you could give us the relationship. And then I saw the word kaulukutu. I think that is tinnitus. I don't know. I think it is tinnitus.
Now, okay,
Mm.
Chris.
Mm.
Let me start with that kaulugutu thing. The kaulugutu can actually be understood differently. It depends on who is using the term. For some people, kaulugutu means noise in the ears without an external stimulus. Or yes, external stimulus, and that is exactly what tinnitus. That is the definition of tinnitus. But for some people, akaulugutu is a sharp, sudden onset of earache. And the majority of those, that sharp, sudden onset of earache is actually otitis externa for the majority. There are very few. Otitis media is not as painful as otitis externa, especially if you have really full-blown otitis externa. It's much more painful, but less damaging to the hearing structure, because the problem just ends in the external ear canal. Once, say, if it is a pimple, we drain the pimple, it ruptures. In many cases, they rupture on their own. We wipe away the pus and the dead skin or another debris. The canal is open and hearing is reestablished instantly. So that is a kaulugutu. It could mean otitis externa, it could mean otitis media, very rare, because otitis media is normally not that very painful. If it is noise, one of the most challenging conditions for an ENT specialist to analyze is tinnitus. Very, very challenging, because the causes are way, way too many. But for everybody on this platform, what you need to know is that in many instances, tinnitus is an early warning that something is going wrong with your ears, even if it is not accompanied by another symptom. It is an early warning, and earlier you have a checkup from somebody with the tools and skills to look through your eardrum and get an insight, gain an insight about your middle ear, the better. That is a kaulugutu. Now, quinine. There is an unpublished research conducted by one of my compatriots at the university M.Med class. He was 1 year ahead of me, Dr. Alex Sandema. I think his dissertation was on the ototoxic effects of quinine, among other ototoxic drugs, and he clearly demonstrated it. A good number, I don't remember the figure, but there is a good percentage of people who receive quinine as medication for whatever reason, whether it is genuine malaria or sometimes in some cases, actually, it is not really genuine malaria. And that we have to emphasize. I have no problem with a person developing hearing impairment because they had severe malaria and their life was in danger. I normally tell people, you'd rather live with a dead ear than die with a healthy ear. But therein lies the disclaimer. Better be sure, you must be sure that what you are treating as malaria is really malaria. I will not blame myself. If I've given you an anti-malarial and it was the only choice I had, you had this malaria, severe cerebral malaria, name it. And in the circumstances, we judge that the best way to save your life is to use quinine. The unfortunate thing you get these days is finding somebody who is walking on the streets with a cannula in their arm, on the streets, with a cannula in their arm, and they have not been tried on another anti-malarial and it has failed. Their degree of parasitemia is not of any big threat. You know, some of these 1+, and somebody is on quinine. These are the things we are trying to highlight, that we should not take it so lightly. Because I feel very guilty if I am the one that I have recommended a treatment for a simple problem and somebody comes back with a problem they are going to live with their entire life. A problem whose solution is much more expensive than what I was trying to deal with. So yes, it is documented. It causes hearing impairment. The good news, by the way, is that most people who have had hearing impairment induced by quinine, the majority, recover from it within 2 weeks. Those have developed hearing impairment. And then another percentage recover within 30 days. Beyond 30 days, and this is what everybody should do not. If somebody comes to you and they have developed sudden onset of hearing impairment and they had some quinine treatment and it is more than 1 month since it started, the prognosis is poor. Once it passes beyond 30 days. At least those are some of the facts I remember from that study of the ototoxic effects of quinine around the year 2000. So that is the quinine, and that's what we have to say. Use it if you must. Be sure you are very justified in your choice for quinine. Where you have other alternatives, start with other alternatives first before you go for quinine. And the same goes for gentamicin. Gentamicin, at the moment, there are so many other superior drugs to gentamicin. Yes, it might be cheap, but buying it, using, saving money through using gentamicin, and then you predispose somebody to a problem where they will need a cochlear implant, which requires more than 50 million. What are the opportunity costs? The equivalent medicine, much as it might be expensive, the other medicine that can be used in place of gentamicin might be expensive, but that cost is far less compared to this person developing a hearing impairment, which require a cochlear implant, costs more than 50 million. So that is, again, as far as judicious use of ototoxic drugs is concerned. Dr. Ndolelile, is there anything else? I'd seen some question in the chat.
The other thing is
regarding noise.
Noise.
Yes, somebody asked you, what is the advice for people who listen to music on, I think, entertainment gadgets through earphones, and they do it at a loud volume. The message is, as we had said earlier, the damage to your ear that comes from listening to loud noise is influenced by 1, the degree of sound, how loud the volume is, and 2, the duration. So if you are listening to it, it is relatively low volume, but you are listening for a long period. And actually the advice has been the safest level of sound volume for you to listen to is less than 70 decibels. Less than 70 decibels. If you are using a gadget, and now the move has been that manufacturers of entertainment gadgets are being advised to include a software within the gadgets that can warn the user that they are approaching sound limits that are unsafe to listen to. This is now one of the moves. When it comes to, there is an advocacy program going on called M Safe Listening. The aim is to influence industry players and manufacturers so that they incorporate in their gadgets technology that can either cut off once you reach a certain unsafe limit of noise exposure, it just cuts off the volume. It doesn't rise beyond that. Or at least it warns you. If it warns you and you don't respond, it cuts off. But if you have a gadget that doesn't have that technology yet, the advice is your limit of volume should never go beyond 60% of the maximum volume that your gadget can output. So always look at the dial. It should, once it reaches, it's approaching 60% of the maximum volume that it can put out. That is the limit you should not exceed. So that is listening to personal entertainment gadget. But there was also a question about people who work in noisy environments. Now the teaching with protecting the ears against environmental noise is that all noise should be addressed right at the source. It's the best way to protect people's ears against noise-induced hearing loss. We reduce noise right from the source. It's more effective to cut it off from the source than for people to protect themselves. But if you have no control over the source of the noise, then there are headphones or earphones that you can wear. In some instances, there are gadgets called the ear muffs, which you can put in your ears, and you cut out some of the environmental noise. How sustainable that one is a challenge, but those are some of the available methods for reducing noise exposure. Thank you.